required to protect themselves. But if they don't believe in it, they wouldn't.
For now, apart from observing symptoms and testing, is any technology now being developed that could detect the presence of coronavirus in people? Is there any technology?
No, so the key diagnostic tool is what we call PCR, polymerase chain reaction, and we're looking for the presence of nucleic acid component of the virus. And if it is present, the PCR test will be positive. So you're actually looking for the presence of the virus, and that's why we have to go to the respiratory tract, the nose, the mouth, and lower down to look for it. And because the test is very sensitive, and it also reflects infectivity, because if you're excreting the virus, you are more likely to transmit it. That's why we prefer that test. The blood tests that you would see all over the internet are very dodgy tests. Some of them have what we call sensitivity of 60%, which means that in 40% of cases, you're likely to have a false negative result. It will come up negative, and in actual fact, it's positive. So those sort of tests, when it comes to screening, are completely useless. If you have a test with a sensitivity of 60%, it's almost like flicking a coin. If you flick a coin, what's the probability you will have heads or tail? 50%. So it's almost like saying, let's forget about the test, Mohammed. Let's flick this coin. Heads, you have COVID. Tail, you don't. And then we flick. And that's how the test will perform. And that's why we don't like the blood test, the serological test, because they look at antibody levels.
So are you emphasizing that now?
So we are. In fact, I believe about a week ago, there was an announcement both by NCDC and I think by one of the health agencies, as well as Lagos State government, that tests for COVID should not be blood tests. We've had people that have been tested with blood tests, and they were labeled as negative, and they subsequently deteriorated, went into a hospital, were tested for PCR, they were positive, and they died. So that's why it's quite possible in the coming weeks to months, because science is moving very fast, technology is developing, it's quite possible we might have rapid tests that are more reliable than what is currently available. But certainly currently what is available are PCR tests, and that's what we rely on.
But closely related to that is what I read in the media. The NCDC is saying that before, at the isolation centers, patients go through 2 levels of tests. That is, you must pass negative tests twice before you are now discharged.
Oh, right.
But now you are saying it's only going to be once you are negative once.
In fact, the advice now from WHO is if you have COVID and you have symptoms, you are isolated, and once those symptoms disappear, and 4 days later you can be discharged. If you have COVID test that is positive and you don't have symptoms, all you need is to be isolated for 10 days, and if you still don't have symptoms, you'll be discharged. The reason being, as I said earlier, the PCR test looks for the presence of nucleic acid particles that represent the virus. But a lot of times, as you go through the later part of the illness, the viruses that you are excreting is being shown are not live. Because viruses, you can take a media, a culture media, and you take the virus and you grow it in a viral media. If it's alive, it will grow. If it's dead, it will not grow. But you can still pick it up from PCR because PCR detects the presence of it. So it's been shown that in the later part of the illness, people can still excrete the virus, but it's dead material, it's dead nucleic acid, and it is not infectious, which is why WHO did the pragmatic decision of saying you don't need to have a negative test to release people. And I think it's very helpful because you can imagine if we have, let's say, 20,000 Nigerians infected, you have to do a minimum of an additional 20,000 tests to release them. And some of them continue to be positive for a while. So you could end up doing 2-3 tests. So over a time, these tests are very valuable, they are precious, they are difficult to get in the market. We could end up wasting a lot of our test kits on people that we already know are positive and have gotten better, instead of using those test kits for people that need to be diagnosed.
Okay, but let's look at those with underlying health conditions who have fallen, most of them have fallen victim, talking about death rate now. When those people are kept in the isolation centers, for instance, someone with cancer or renal failure, something like that, or what do you call it now? Yes, cancer, kidney problem, and all of that.
Diabetes too.
Diabetes, yes. Do you have specialists in those areas equally taking care of such patients?
So,
Because I'm like, I know that the isolation centers across the country are not at par with each other in terms of
no,
quality.
they are not. So there are two levels of isolation or treatment facilities. There's the level where people do not have symptoms, they just have a positive test, or they have very mild symptoms, and they are put in isolation facilities where they are just monitored, but they are not being given anything because they are well. And 80% of those that catch COVID will be in this category. Then we have 20% that are sick. These are the ones that usually require antibiotics because they have a pneumonia or they require oxygen. Those 20% are the ones most likely to die. And they need to be in a facility that can look after them. So that's why we said for facilities that require additional level, they have to be teaching hospitals or federal medical centers. There are a few private hospitals in the country that are very good and have been validated to have COVID patients. But certainly the people that are most at risk, if you look at it, age is a major risk factor. In Nigeria, those if you're above the age of 60, the mortality, the case fatality rate is 17%. At the moment. So that's almost 1 in 5. If you catch COVID and you are above that age, you have almost a 1 in 5 chance of dying. Obesity is a major factor globally, internationally, in terms of severe illness. Diabetes, and especially uncontrolled diabetes, is a problem. And then cardiovascular disease like hypertension, heart failure, etc., put people at risk. But the good thing is the majority will be fine. 80%. In fact, the Chinese cohort, for instance, in Wuhan, etc., when the epidemic was over and they analyzed their data, 92% of those that had COVID fully recovered, no side effect, nothing. So what we're trying to say is we are trying to protect those that are vulnerable in our population, because yes, it's a pandemic. It isn't a terrible pandemic in terms of Spanish flu, etc., because flu, it doesn't matter. Even if you're young, you can get severe flu and die. And in fact, even in Nigeria here, we were looking at some of the data for FCT yesterday. I was at a meeting of the FCT. And what was interesting was that the youngest person to die was actually 38 years old. The range was between 38 to 60-something years. So this is why I cannot predict. Let's say I'm much younger. Mohammed, I'm getting old, just like you. But let's say I'm much younger. I still wouldn't want to catch COVID because I don't know whether I will fall into that 20% group of requiring oxygen and becoming really unwell, or I will fall into the 80% group that I'll be completely all right. And the best way to remain alive, because the game now, the priority for all of us is stay alive until this thing is over. That's the priority. So whatever we need to do to stay alive, we should. And the best way of staying alive in the current context is not to catch COVID.
Well, the general understanding in the media is that COVID-19 is viral. And but I want you to use this medium to clear this conspiracy theories that Italy went ahead to do autopsies to some of the dead patients that died as a result of COVID, and they discovered that it is not viral, but bacterial. How true is that?
So there's a lot of confusion here. In the first place, most centers that I know wouldn't even do post-mortem. Why would you need to do a post-mortem on a COVID positive patient who's died? We know what kills people when you have a viral infection, like influenza, for instance. Usually it's not just the influenza, it's actually the secondary bacterial infection that you get. So with COVID, for example, the first week, people will just have a bit of a cough and a bit of a cold. And you would think you'd be all right because it's a very deceptive illness.
Yeah, like the common cold.
Yeah, like the common cold. Oh, I have a bit of a cold. It's going to go away. And then a week later, it hasn't gone away. Then you start running a fever. Say, this thing is becoming a nuisance. And then by the third week, you develop straightforward pneumonia. You develop a bacterial infection and a pneumonia because the virus is progressively chewing away at the lungs. And there's a battle going on in your lungs between your immune system and the virus. If your immune system overcomes the virus, which is what happens in 80% of people, the virus disappears and the lungs recover. If it doesn't, you will continue to think that you will get better until a large chunk of the lungs is taken up, and then the oxygen exchange becomes inadequate, and that's when people start requiring oxygen, and then that's when trouble starts. They then go onto a ventilator, and if the illness progresses, that's it, because there's nothing to interrupt the progression except your immune system. When it comes to most viral infections, your immune system is the only thing that will stop it. A lot of the antiviral drugs we have, like for flu, for instance, reduce the duration of symptoms by 24, 48 hours, but they do not stop the infection altogether. We still rely on your immune system. Even the drugs that we are currently trying for COVID, the clinical trials that are going on, the drug that looks most promising is remdesivir. But it's very likely remdesivir will turn out to have very similar effects to oseltamivir, which is the one for flu. It probably reduces the duration of symptoms maybe by a day or two, but it's unlikely to sort of give you that sort of effectiveness of saying, right, I take it and everything stops.
Okay, since
So no drug yet?
No drug that's effective, none.
Okay, so since strong immunity, plays such a vital role in minimizing the impact of COVID-19, are we giving it the necessary attention or push, as we talk to our people? What sort of, support, is the national response given?
When it comes to immune system, there isn't much that you can do to your immune system. People talk about boosting your immune system. It's either you have a good immune system or not. What affects your immune system? Diabetes does, because the sugar is toxic to a lot of the white cells and the way the white cells function, the B cells, the lymphocytes, etc. If you have, let's say you're on steroids or cancer drugs, it brings down the immune system. In terms of obesity, the problem with obesity is not just the immune system, it's actually the way your lungs function and the rest of your cardiovascular system. And the reason why with hypertension is such a major risk factor for severe illness with COVID is because COVID tends to cause clotting. It increases your propensity for clotting. So if you have clots in the major vessels, the heart, because the heart pushes blood into your lungs. So if you have a blockage, what happens? The heart will have to push fast, more strongly in order to pump blood. Yes, and COVID has been shown to have an increased tendency for clot formation, either in the large vessels of the lungs, etc.
So there's nothing like boosting the immune system?
No. What I would say is you take good food.
When you talk about adaptive immunity,
you take good food. I'm not a strong proponent of saying take multivitamins, vitamin C, etc., because I'm afraid scientifically that evidence is very weak. What you need is, if you are able to get good food, nutrition. The reason why children that are malnourished die is because their immune system is down. So if you are well nourished, Mohammed, like you're always very well nourished. There's no reason why you need to add anything other than continue to take the good food.
Proven that I look well nourished, maybe.
No, I'm sure you are.
So what you are saying, in essence, you said you are skeptical, about asking people to take vitamin C. Well, what about in their natural form?
In the natural form, that's why a good balanced diet is important. You need vitamins, but the vitamins you will get with a good balanced diet is enough. What I'm trying to say is people shouldn't waste their money buying multivitamins, etc. They should spend their money buying good food for themselves and their families.
So you are not a supporter of supplements, for example?
No, I'm not. But supplements have a place in the elderly, for instance, where you have issues with malabsorption. You cannot absorb certain vitamins, etc. Or if you had surgery of the stomach and you have reduced stomach content, etc. But if you don't have those background medical issues, what you need is a good meal. A good meal will give you all the nutrition you need.
A good meal, but it's always sad that we don't always get our daily requirement of such nutrients from just eating.
Is it not cheaper to buy orange or banana than it is to buy a complicated, sophisticated multivitamin container?
Well, Doctor, let's come back to the basics of this discussion. What would you say now is the rate of community transmission across the country?
I would say it's ongoing. There's no doubt about it. The virus has escaped into the community, and that's why with the current phase that we are in, we've identified 20 local government areas or so that are responsible for about 60% of the infections. And
20 local government
areas.
How many states?
I can't remember the complete number of states, but it's Lagos, Kano, Jigawa, Bauchi, and a few other states. I think about 5 or 6 states. And these have the bulk of the infections that we see in the country, and even a lot of the new infections are coming up in those areas. So our emphasis with the current phase of the response we are having is, instead of locking up whole states or a whole region in the country, it's easier to put out small fires than to put out a large one. So we are strategizing. We're putting a bundle of measures, including increased testing in these local governments, going house to house and trying to get people to test, increased surveillance, isolation, making sure there are community isolation centers enough available that we can take out people from the communities that are positive, providing people with palliatives, and so anybody who's tested positive, for instance, in the place, when you take out their breadwinner, you provide them with additional support, and you convince them to stay at home, and you lock up the areas.
Okay.
So that's the strategy we are looking at. And the other important bit is we are doing a lot of risk communication and community engagement. So a lot of people at the local government level, just a day or so ago, the National Orientation Agency was able to do activities across all the 774 local governments in the country, and they had people going around with loudspeakers, with announcements, and engaging with the communities, the community leaders, the religious institutions, etc., to educate them. Because, to be honest, the only way this thing can stop is either of two things. It's either it goes through the population and the majority of the population develop immunity to it, and then the transmission stops, what we call herd immunity, or we change our behavior to the extent that the environment becomes so hostile to the virus, and the virus disappears. For countries that have lockdown, for instance, if you look at the data for China, for Germany, etc., what happens is, with about 4, 5, 6 weeks into a lockdown, you get a sudden drop in transmission. The numbers just precipitously fall. And the reason is because transmission is no longer efficient. You have interrupted that ability of an infected person to transmit to the next, and that multiplies several fold, and the epidemic wanes.
Okay, I was actually going to take you up on striking a balance, between preserving livelihood and ensuring health safety. And with this introduction that you just mentioned, that's going to take place within the rural areas, what mechanism is going to be put in place to ensure that it doesn't get abused? Because we're talking about rural areas where poverty level is high, and when people get to know that, if one test positive for COVID-19, a breadwinner especially, it's taken into isolation and the family is catered for. Don't you foresee, abuse of process?
No, because it all depends on what? On an intervention
does
called
it cut
testing.
Across
No.
every household?
No, it depends on testing. Okay. You have to be positive in order for these interventions to come in, remember? And those tests are not done by the communities. They are done by people who have been trained to do the test. And to me, I would rather stay at home with my family than to be dragged out and put in an isolation center because you are providing money for my family to feed over the next 2 weeks or 3 weeks.
There are people who rather opt for that. That's why I asked.
So no, provided we are not, there's no evidence that we are interfering with the test results, and we know that the test results are very reliable. NCDC has done an excellent job. NCDC didn't exist 4 or 5 years ago, and we are so lucky to have an institution now like that. Otherwise, it would have been a lot more difficult to get on top of this problem. But I certainly don't expect people to use the opportunity to just get palliatives. The sad thing is we know that a large chunk of our population live from day to day. They have to go out to get their daily bread, etc. And that's why we are trying to balance the two. So even some of the relaxation, if you look at some of the relaxation measures we did, it was partly to enable the economy to restart and for people to be able to feed themselves. Because no matter how much you want to protect yourself from COVID, if your stomach is complaining, you have to go out and get something to
hunger COVID.
Exactly, which is stronger than
now the interstate travel is still banned. Is that lifting of that interstate travel dependent upon resumption of schools and other higher institutions as well, or reopening of schools?
Well, a lot of the decisions we take, Mohammed, in the PTF is they are joint decisions based on the data we have. We have modeling groups that assist us. We have academics that we provide them with questions, simple questions like what is the impact of relaxing interstate lockdowns, for instance. They will do the modeling and show us how it's effective or not. For example, when we lifted the lockdown, there was a piece of work that was done where we said compare complete lockdown with this raft of interventions, assuming people comply with it. And what the modeling showed very clearly is if everybody washes their hands, sanitizes their hand, use face masks, maintain physical distancing, avoid mass gatherings, etc., the impact of that at a population level is no different to a complete lockdown. And you can understand why that will be the case, because if I maintain all this, I'm not going to transmit to you. So the outcome will be the same as me locking myself in a room. But of course the compliance turned out not to be what we expected. But going back to your question about whether we are going to open interstate or not, we are monitoring things very closely. As you know, we said to the aviation industry, June 21st, get your act together. If you are ready, let us know. And it's not possible to open the skies in terms of domestic travel and still keep the roads closed, because that would be very elitist. So we will review that process when the time comes. We hope that some of the states, one of the reasons why we didn't open up is because we have states that have such a high burden, and they are neighboring states that have such a low burden of the illness. And the moment you start, people start moving, then that infection will spread.
That's something.
So what protocols, Rabi, I will soon allow it. What protocols is PTF considering before it reopens schools?
Oh, schools.
Yeah.
Okay, so with schools, there's very good scientific data that suggests when the impact of reduced transmission, the most effective intervention is really a lockdown, because it gives you a 45% reduction in transmission. The next most effective is locking down schools, and that gives you a reduction in transmission of about 15%. All the others, like hand washing, like physical distancing, like use of face masks, they give you reductions of about 5, 6, 4%, etc. They are single figures. And the reason why schools are closing down schools is so effective is because of a mixture of things. One, the difficulty in getting children to maintain all these raft of measures. B, the fact that children are more likely to be asymptomatic or have mild illness, so they will not be picked up early. 3, the way that children play as well, and they sniff around, they cough, etc. And then fourthly, the impact this will have on mortality, especially in the elderly, because a lot of children go back to their elderly grandparents, etc. And this is the very group that we want to protect. So you end up, what you end up with is the children will not have a problem. Virtually the majority of them will all be fine. But you end up having a spike in deaths related to those relatives. So that's why we are being very cautious. We understand the concerns of parents. I have a child myself who she hasn't been in school for weeks now. And of course, as a parent, I will be worried. But we need to make sure that when we open the schools have put in place all the necessary measures required to protect the vulnerable within our population.
Okay, there's something that is quite disturbing, and I'm considering the physician oath of the doctors now. In the face of COVID-19, there's a rise in the incidences of maternal mortality, and with some hospitals rejecting women, pregnant women or women in labor and all of that. What is being done to conscientize the minds of these hospitals and even the professionals who man them? Why should pregnant women be at the receiving end?
Rabi, it's not even pregnant women alone. Okay. Across the board, hospitals are there to treat people. There is absolutely no excuse for a hospital to turn back a patient because the patient may or may not have symptoms of COVID. What we've said repeatedly, both at the PTF and also the Minister of Health has written several times to heads of teaching hospitals, federal medical centers, etc., is they need to have a triage system. They need to have a holding area. So if you go to the National Hospital now, there's a holding area for people with respiratory symptoms. They put them aside, they assess them, etc. And then, if they are COVID, they are still looked after. It is unethical, it is wrong, it's criminal for people to be turned back when they need help. Our suspicion, even for some of the deaths that have been happening, is partly because of the difficulty of people accessing healthcare. You have people that are diabetic. They run out of their medications, they need help, they go to a hospital, they are turned back because they have a bit of a cough. That's unethical. And we are monitoring it very carefully, and we certainly feel we are already engaging, and a lot of the professional associations like NMA, etc., understand where we are coming from, and we have provided, particularly the federal teaching hospitals, we provided them with PPE to make sure that the healthcare workers are protected. But you don't turn back somebody who is sick and seeking help. That's why you are there as a hospital. That's why you are a doctor or a nurse.
It worries me that 25% of total deaths from COVID-19, are health workers. Why is it so? If health workers are being provided with the appropriate PPEs, is it lack of knowledge on how to keep safe or negligence on their part?
And so I wouldn't say negligence, because nobody will go out deliberately to catch an illness that is potentially life-threatening. But there are a mixture of things. In the first place, if you look at the private sector, for example, the private sector are there to make money. And let's be frank about this. And they need to provide their own PPE. They need to, because government cannot accommodate the private sector. Even at the federal level, we are accommodating the federal teaching hospitals and medical centers, and we are providing PPE to the states. But primarily, the states are also supposed to fund PPE for their own state hospitals. What is happening is you have a mixture of things. One, you have poor training. NCDC have trained about 13,000 healthcare workers so far in the country, which is great, but we still have a very long way to go. Two, we have a lack of perception of risk by some healthcare workers. So, for example, if you go to some of the private hospital setups, they may not necessarily realize that somebody presenting with a fever and malaria is negative, blood cultures are negative, still running a fever, very unwell, could potentially have COVID. Thirdly, there's also the issue of correct use of the PPE. So, for instance, sometimes I see people in public wearing this PPE with their nose out. or putting it on the chin. I'm not aware that you can breathe through the chin. Maybe it's a new new sort of fashion. So for PPE, for masks to be effective, and this has been shown consistently across studies, you need to have population level use of masks. The majority of the population need to be able to use it and use it properly. If I'm in a hospital setup, let's say I'm back in the UK, I'm on my infectious disease ward, I would never touch the outside of my mask. I would never remove my mask to talk to you. I would never touch my face. So all these are really important things. And then finally, the PPE that we provide, we have what we call rational use of PPE. The other day, somebody was being assessed in a hotel. The person that came to assess him, this is a visitor to a hotel who wants to book a room, but the person that came to assess him was dressed in full regalia, had the coverall, he had the gloves, he had the boots, he had the mask, he had the face shield, and he didn't need to have all that. Because this is somebody who is just coming out from the public. All you need is a mask. You don't even need the gloves. So those expensive PPEs end up not being used appropriately by the hospitals. They run out of the PPE, and then of course they start managing things, and then
Doctor, before we go, what will you say now is the update on the validation of the three identified local claims for treatment of COVID-19, and of course including the Madagascar solution?
Well, I'm afraid I don't have any information on that. I know Mr. President gave quite a clear directive that the Madagascar drug in particular needs to go through the validated steps. And it's been forwarded to the relevant health agencies. People who make claims, it's very easy for me to come and make a claim and say, actually, if you take this, Mohammed, you'll live 100 years. But it has to be proven. We've been through this with HIV. I'm not saying the claims, etc., are wrong, but what I'm saying is they have to go through a process. And that process takes time, and you have clinical trials, etc. And even in the concept of a pandemic.
Report in terms of the update.
I wish there was, because it means we can all say it's all over, isn't it? But it's not. There's no, even within orthodox medicine, even within normal medicine, the scientific community, there's no treatment at the moment that's been proven to work for COVID.
Okay, beyond that, do you believe in medicine sufficiency, medicine availability as a security issue? Looking at the Nigerian situation.
Absolutely.
Looking at the Nigerian situation, what has COVID-19 taught us in that regard?
Absolutely. We have to look inwards.
Ahead.
But we have to look inwards, particularly in terms of manufacture of drugs that we already know work. So look at what happened in India when we had the COVID pandemic. A lot of the generic companies were told to stop exporting drugs. So suddenly we had shortages. We had shortages of chemotherapy drugs. We had shortages of HIV drugs, etc. So that's the more reason why we need to invest in technology. We need to invest in biotechnology to make sure that we are prepared as a country. We have the manpower. There's no doubt. We have the scientific minds. All we need really is the additional investment required. NIPRID, for instance, have been doing some good work when it comes to pharmaceutical, what we call active pharmaceutical constituents. These are the things that you use to APIs. They've also been doing a lot of work with this liquid gel sanitizers. They did some survey and testing that showed that some of the sanitizers were not really up to grade. Apart from NIPRID, we have NIMA, the National Institute for Medical Research in Yaba, and they are doing the current Solidarity trial that the WHO is involved with. So there's a lot going on, but research requires money. If you give me 30 million for research, and meanwhile there's an external body outside the country that is receiving 3 billion, who do you think will be the first to get a cure? So it's a non-starter in the first place. I think one of the things that we will post-COVID, there are certainly spin-offs that would happen. One is, I'm sure, that even the way we fund health will change, the way we fund education will change. Infrastructure is an excellent idea, but infrastructure alone does not develop a country. They need to go hand in hand. And then secondly, the way that we perceive health in totality across the board will change. So even when it comes to investment, in the past people would rather go and be involved in road construction, etc. But it's very clear, no matter how rich I am, and I'm not rich by the way, but no matter how rich I am, if COVID gets me in an environment where I don't have access to ventilators, we have about 200 plus ventilators in the country, 200 plus, that currently ICU, in terms of our ICU bed capacity. There are hospitals in the UK, like our hospital has more than 50 beds. There are hospitals in the UK, the large ones, that have more than 100 beds. So, and you know that your chance of survival depends on having this equipment. It depends on having the doctors. It depends on having the healthcare that would protect you. And I think as we move along post-COVID, we are probably going to see a lot more investment in health. We are already within our budget. We have put in place arrangements to have an isolation and treatment facility in every state, the 37 states, linked to a federal teaching hospital, and also 10-bed ICUs linked to every federal medical center or federal teaching hospital. And it's not even a huge amount of money, to be honest. 5 of those could be paid for by just getting people that are being evacuated to pay for their accommodation.
Let's look at the primary health care component of the response, the response to COVID-19 now. Well, I don't know, I might be wrong, but I'm thinking it didn't take off early enough until we got to the community transmission stage. Why was it so?
So, a good question, Rabi. So, at the beginning, usually with a pandemic, at the beginning you have the first phase where all you're trying to do is those few people that are infected should not spread it. And it's the same approach we had for Ebola, for instance. So you pull all your resources into those few cases. So, for example, if you remember, we closed flights. There were people trying to come through the land border. We put resources to stop them, enforcement, etc. If you are positive, we drag you kicking and screaming. You don't want to go. We will put you in an isolation facility, even if you look well, and we'll lock the door, etc. But at a certain stage, the virus escapes. And when the virus escapes, that's when the community element comes in. And at that point, what you are trying to do is to mitigate. You know that it's already spreading, but you want to slow the spread so that you'll have enough time for the health system to be able to recover or to be able to cope.
Yes.
Yeah. And that's the stage we are at. There's no doubt there's a lot of community transmission going on. There's no doubt we cannot absolutely 100% stop all transmission. But what we are trying to do is to stop as much transmission as possible and particularly protect those that are vulnerable, that are likely to die if they catch this illness.
Doctor, very quickly, we have just 1 minute to go. What will you say informed the decision to suspend evacuation of Nigerians abroad?
So the problem we've been having, Mohammed, is